Good morning, Dr. Aziz, Dr. Aziz Halawi, and Dr. Aziz Husni, and everybody. I'll be presenting the FICO case that we did on Tuesday, which was on 17th of August. Patient's name is Ahmad Faisal bin Mat Saleh.
You need to mention name. You need to mention name.
Okay, sorry. He's with underlying diabetes, hypertension, dyslipidemia, chronic kidney disease, and coronary artery disease. A case of left eye cataract, right eye pseudophakic, and right eye severe NPDR with left eye ADED with vision of counting finger 3 feet. So I fast forward a bit, doctor. To start with, the pupil was a bit smaller, so I was giving the intracameral adrenaline.
Show us the part that you have problem.
Okay, then main wound, hydrodissection, and was sculpting it, and then managed to crack to heminucleus. This is the part where trying to take the quadrant.
Look at parameters, guys, on the left hand side.
Part of heminucleus is out. Then rotating to the nucleus now, and trying to crack it again, but difficult, so I sculpt the heminucleus. And trying to...
You're moving your FICO probe so much, right side.
Yeah, doctor.
The last segment,
Yeah.
Last segment.
Yes, doctor.
What's the difference, Stella, in terms of the parameters? What's changed from the earlier one?
Since it's a bit difficult to remove, and then it's already thin nucleus, we changed to epinuclear setting, and then this the part we...
Stella, can you stop for a while? What is changed, the parameters, from the high setting to lower setting? What is changed? The water height? Water height maintained, is it?
Water height maintained.
What is changed then? Ultrasound.
Ultrasound.
Tak tulis apa-apa. Vacuum 50 to 200. You go back to your high setting, the earlier one. You look at your right hand side.
Right hand side.
Right hand vacuum 200, 380. So when you change to last setting, what is changed? Right upper corner, you know the parameter there. Okay.
The vacuum became 50 to 200.
Vacuum lower, right? Vacuum lower, ultrasound lower.
Ultrasound lower.
What is DC?
DC.
The water height is maintained because of the adaptive fluidic thing. Betul tak?
Yes.
Okay.
So we noted already the PC ran here, and
What happened? Can you reverse it? Why did it happen?
so while removing the
This one.
Yeah, we were So we were like going on taking, but it was okay. Then this the time we noted, behind got PC run. Then we stopped.
Why do you think is the issue here?
Uh, May
Ada Amira kan ada kan? Bukan Amira, Shikin.
Shikin was there.
Yes, I
I was I was not watching this in OT. I was away.
I think that's what you say. That's what you say. Once we change and if the setting from the apa tu panggil, from the segment removal or chopping punya mode to appendicular setting, so there will be reduction in the vacuum as well as the power lah. So although the motor height is maintained, so there will be like changes in the turbulence. So there will be the AC is not maintained, and the posterior capsule actually can flip up, then can touch the probe lah. Yes.
Why shouldn't it not maintain? Because there is the
Can I ask a question?
Go ahead.
Why is the second port so hydrated and large? I mean, just now when the surgeon was trying to, you see, there's a lot of fluid coming from the second instrument. Just imagine, because basically you cannot maintain the AC depth, and there'll be a lot of fluctuation if the second port is not maintained. And if you also notice, it's very hydrated, at the second port. Thank you.
Okay, doctor. Noted.
So put the height all the while the same way and 50 because this is using adaptive fluidics. So it's probably because of the wound. Now you're pressing the wound, the left wound, press down, AC come up. And the other thing is that you shouldn't be moving your right hand at all. So that's to prevent, because we want the phaco tip to be at the safest zone inside the eye, which is at the center most. So it shouldn't be moving at all. So the one that you move is your left hand, the dialer.
Okay, doctor.
Prevent all this unstable AC.
And then we put in our viscoelastic to tamponade. And
forward.
Sorry, doctor.
Forward to the part that you want to show us.
Oh yeah. Then we proceeded with the anterior vitrectomy, and then while we doing the anterior vitrectomy,
Sekejap, ada soalan. I would like to ask if, let's say, stop sekejap. Last segment kan, you have a large PC run kan? Will you convert? Siapa boleh tanya sini? Bukan Mani jawab Mani. Mana Mani? Sini? Shui?
Yes, doctor.
There's a large segment, let's say 1/4. Then you have PC run, big PC run kan? So you tamponade everything looks okay. Will you convert?
If the rent is very large already, then I might consider lah, doctor. Because I'm scared.
Okay, the moment you convert, then you may push the segment down to the PC, but you can scoop it out now. But is there any other option?
Other option?
To maintain a small wound is actually better, isn't it? Because when you want to convert, you deliver the vitreous as well.
Yeah, understand, doctor. But because I think sometimes if it's too large, also we are worried. Sometimes once we enter with the phaco probe, then the nucleus just
because it's not enough. Not enough tamponade, and you didn't reduce your setting down.
Enough lah. Okay, doctor. Understand.
But bear in mind when you convert, when you deliver, you may deliver vitreous as well because of the PC run.
Yeah, okay.
So Stella, show us what you all did.
Yeah, and then when the nucleus fragment, less than quarter nucleus fragment is actually came up by itself, we didn't dig out. So once it's near the pupillary margin, and then yeah, we put in more viscoelastic under the nuclear fragment to float it at the anterior segment, and then with advice by Dr. Aziz also, we proceeded with removing the part of the remaining nucleus with phaco probe.
With the phaco probe, but using the low setting, the low vacuum and also low power, which is we are using the epinuclear setting at this moment.
So what did I tell you? Okay, you have to go direct to the segment.
Yes, we have to go to direct. So basically maintain the probe at the center and then rotate and also bring the remaining nucleus by using the second instrument towards the probe, so that we don't aspirate any viscoelastic.
Yeah, that's the
instead
word.
of the nucleus.
Aspirate the visual. You shouldn't aspirate your tamponade.
I just want to ask, pertaining on the question just now, would we convert at this moment? If in case kalau macam this patient has quite we call is a dense nucleus remaining dense nucleus, and also is hemi-quadrant. So do we consider extend the wound and deliver the nucleus by using?
It's answered already. So what do you think?
So I think it depends on the depends on the density of the remaining nucleus. Kalau let's say it's big enough, and we don't think that we can remove by using the low setting of the phaco probe, and also the extension of the PC rand is quite large. So we would consider extend the wound and deliver manually.
You scoop it out.
Okay.
But in good hands, and they don't normally extend the wound because they have to keep the vitreous within the closed cavity, small wound. They don't want to extend.
Okay.
Depends.
Right.
It's all about prevention of PCRN, isn't it? So your right hand shouldn't be moving to pick up all those pieces. You should just stay.
Okay, doctor. And then
okay kan, yang ni kan?
yeah. After that, we proceeded removing the cortex, and then
tak ada drop kan?
no epinucleus drop, and then we injected myostat. The pupil became well round and smaller. There is no any vitreous in AC. Then we proceeded with insertion of the ACIOL.
Explain to us why not sulcus.
We did not proceed with sulcus lens in view of the large PC lens, which was from 2 to 7 o'clock, and the back is not stable.
Why not stable? I thought I asked you dating hand. Why not in sulcus? PC rand is not the contraindication for sulcus. It's a different support.
The zonal dialysis also.
Betul ke zonal dialysis?
Because doctor, because I think the PC rand is large enough, and we do assess prior. Initially actually we do consider of putting the sulcus, but when we assess the CCC, actually it doesn't look intact lah. It was eccentric, so that's why I didn't dare to put sulcus.
Acondylolysis lah. Okay.
Yes.
Yes.
So you have to be very clear, why you're putting ACI. People will ask, why not in sulcus?
Yeah, the CCC not.
The PC rand is not equal to zonolisis. So when it's a PC rand, whatever sulcus is ada. Lah, putus-putus apa tu? Line tak okey.
No.
Apa tu Irene Line tak okey lah Irene.
If you cannot see the entry capsule, that's why you worry. You cannot put in the sulcus. Bukan it's not intact, it's more eccentric tak. You cannot see the anterior capsule to large enough to support your lens. Oh, lens tak okay
Dah okey dah. Tadi breaking up.
Hello, okay.
Okey dah.
Hello?
Okey dah. Okey Irene, okey. Dah okey dah.
Dengar dah?
Dah.
Yelah, line not so well. Okay, it's not that anterior capsule is eccentric, CC eccentric or not intact. Dengar dah? Is that if you cannot see the anterior capsule very well, and the CCC is standard very large, that's why you cannot put in the sulcus. Kita worry about that. Tapi most of the time, you don't touch your anterior capsule tu sangat. Should be okay. Selalunya you can put in the sulcus. Dengar tak?
Dengar
Saya
dah.
cakap seorang-seorang.
Boleh.
Boleh dengar.
Okay, thank you Dr.
Line tak cantik.
Around.
Thank you, Dr. Ali. Thank you, Dr. Hairin.
The reason why we put up this case kan, because I noticed when you all do with stellaris kan, when you do high setting chop kan, you shouldn't see flutter, iris fluttering. Meaning the setting is alright. I've called BNL Orbit Medical to come, Ijat to come over and have a look again. Takut adaptive fluidic ni tak push fluid no. Because the bottle height is only 50 and I doubt I had 50 during my setting.
Ada delay je.
Lepas tu semua 50 I notice 50 cm only. And it is adaptive fluid. Takut adaptive fluid tak berjalan. Because you shouldn't be having fluttering when you do high setting, vacuum high, and iris bergerak tau. You shouldn't. When you use the other machine kan, have you ever seen iris flutter when you're removing segment? So I saw on Tuesday kot. Betul lah dia Shikin buat kan. Fluttering of iris. You shouldn't have that. Iris sepatutnya fix. Dia tak jalan. Takut ada adaptive fluidic issue. And when you change to the last segment to remove last setting to remove last segment, it will be worse because of the low setting. Kan? Okay dah. Next case boleh? Ni okay kan? Patient ni okay kan?
Dah okay dah.
PI is naturally done. Ni automatically done. Kan? PI tak buat kan? PI yang tu.
PI was hydrogenic noted at 3 o'clock.
Okay.
Thanks, Dr.
Kena buka terus. Kenapa space? Assalamualaikum Dr. Aziz and everyone. Boleh dengar ke?
Boleh. Apa ni? Salma kan?
Salma. Sorry, sama dengan Mahani dekat ITD.
Go on.
So I'm just sharing a case last week. This one started by Dr. Ida. This patient is a 66-year-old Malay lady with no non-medical illness. Start with necklace management. The issue we had during this surgery was that vacuum dia tak jalan. Sorry. Hello?
Dah, boleh dah. Go on.
Sorry. So the issue with this cataract surgery that we struggled was that somehow on that day we had the old probes, so our vacuum didn't how do you say didn't
Video
did
tak
not
jalan, tak nak buka dulu video.
video tak jalan.
Video tak ada.
Kejap
I think you have to open the video first, then you share it. Sama.
Tak ada video.
You have to
Stop sharing. Oh, stop sharing this window.
How do I open this?
Stop dulu window ni. Share another one.
Sekejap
On dulu.
technical issue. Sekejap.
Okay.
Stop share. Dah stop dah kan?
Dah stop. Sekarang you tekan ada share screen dekat bawah.
Okay, so I buka ni dulu.
Oh, you nak share screen.
Kan buka ni dulu. I think tadi that's why kita tak jadi ke. Tak buka pun. Sorry.
Kejap Stella, what was learned during your case? The lesson that we learned.
The ACIOL lens.
The lesson. What's the lesson learned? First case.
Oh, lesson. Yeah. During the, this is the first time learning that.
Tak Dr. Aziz? Oh, sorry.
Yeah, Stella. Go on, Stella.
Yeah, initially we were taught to, when we are coming to the last segment, to change from our setting to epinuclear setting, but I learned that not to change and to proceed in view of the change of the setting causing changes in the parameters. So the tendency to have PCRAN is higher.
Why?
Because of the fluttering of the posterior capsule and
Okay, dia macam ni tau Stella. I've talked to all of you. When this conventional teaching of changing to last segment or to remove last piece, there's a reason behind it. When it's been passed down from generation to generation. When we started using poor machine, for example, last time Legacy, all those Millennium, White Star, the old technology, they have this occlusion surge. Every time, every step after occlusion, there'll be a big surge. So that includes when you are chopping. But chopping it doesn't matter because you have many segments. So when there's a surge, you will catch another segment. So your PC will be safe. So when it comes to last segment, there's nothing to catch after the last segment. So that's why people reduce the setting. Betul tak? They reduce the setting. So they will not, when they have this occlusion surge, they will not catch PC. And they do slowly. So with this new machine, Signature Pro, this Series Elite, Centurion, they don't have this occlusion surge. And the PC will just stay behind. And when you come to last segment, there's actually absolutely no need for you to change your last segment. And because the PC is there, unless you are moving your segments, you're pressing your wound, and you're withdrawing your probe, which makes there's no minimum aspiration, but you are aspirating. A minimum irrigation, but you are aspirating. There's your PC coming over. There's no reason for you to change your last segment. Changing to last segment because, for example, when you are doing high myo, high setting, when you remove segment, when you come to last segment, you change your last segment, the PC all will come forward, because of the lower setting, lower water height, and all this. Okay.
Yeah.
You have to understand the steps behind every step in cataract surgery. Then you understand. Then you can prevent this PCRAN.
Yeah.
All right.
Understand.
Okay.
Okay. Thank you.
Okay, so for this case, again, Dr. Ida started for me and did the cracking. She separated the lens into small pieces for me. Then sama start from segment removal onwards. From okay, so this is when I started. So the issue with this case was that during my surgery, there was issue with the vacuum. The vacuum was working. When you tekan, memang the vacuum went up to 300, 400 sampai maximum tekan, but then somehow dia not effective. Somehow the lens is not coming towards the probe.
So what's the problem then? Where is the problem?
Well, we were told that memang it was the probe punya issue lah. That is an old probe.
Did you all change the probe?
Tukar, masa ni tak tukar. I think after that baru kita orang try to tukar masa IA.
Lepas tu tengok dia punya kaset tau, kaset tentang peristaltik dia tak jalan.
We change cassette also. Itu pun masa IA juga.
Rotating blade tu, dia punya rotation roller tu kan.
Because the first case we had that similar problem. This case, I didn't realize halfway until then I realized it was difficult lah when I wanted to do the segment. Baru perasan that the vacuum tak so effective.
You have to change it lah. And please don't put it back into the circulation. Yesterday, we came over and ambil balik. Tapi dia masuk balik circulation. Masuk apa ni? CSSD balik, autoclave. Alright.
Okay.
So this is the probe with the problem.
Apa dia?
Ini dah tukar dah. Probe dah tukar.
Ni belum tukar, ni macam baru nak, this is the masa nak start lah. And then memang towards the whole case ni memang we suffer juga. I think the third case onwards tu baru dia okay. Because when we change second probe pun sama juga.
Just happen that they're consecutive lah. Sama probe, ada few probes yang ada isu ni.
So so this sama was doing and it was a hard cataract, so it was a bit difficult for me to do segment removal.
Yang ni apa ni? Yang ni setting chop kan? You look at left hand side kan?
Chop.
8/4 tu katanya jalan tau. So it's not working. The probe yang tak ada, it doesn't have that vibration. Faham sama? 8 on, 4 off. Macam tu lah. So when you actually press your foot pedal, as you press your foot pedal, the thing changes.
Yeah.
Punya time off, time on kan? Supposed to change, but it doesn't change. It's your probe issue. Cuba tengok case lain nanti. 8/4 ni kan, this is the on-off time. The cycle, duty cycle.
Sorry, actually Dr. Aziz sama tak faham the on-off kat mana?
Bukan, it's on FICO, off FICO. The duty cycle, you have to read about the duty cycle. So as you press down your foot pedal, you actually on your FICO, how much is on per millisecond kan?
Yang dekat bawah hijau power ni kan?
Buat makna dia tak jalan lah. FICO tu tak jalan.
Maksudnya FICO tak jalan?
FICO, vibration, you have to read. You have to know your machines well. Daripada parameters lah.
Okay.
Vacuum jalan, tapi on off tak jalan. Dia on 8 je, dia off 4 je. Macam tu tau. Per second.
So how? So memang
tukar
change probe lah, Dr. Aziz.
Yes. Tapi ni continuous. Sekejap, continuous. Cuba tengok nanti you change your setting. Dia berjalan tak? Because patutnya Y-star, as you press, you get this on-off time. It's supposed to change.
So towards the last piece tu lah dia struggle masa, and then the patient punya PC was quite near to the anterior, I mean it's not that deep, so it was quite scary juga lah, but alhamdulillah there was
Berapa Feco power sama?
apa dia?
Feco power.
Your Feco power.
40.
Tak cukup
Tapi bukan, dia maximum 40 but it's less, so much less. Dekat bawah sekali, dekat setting left,
Ya.
right hand side dekat bawah, tak nampak. Ada hijau-hijau tu.
Much less lah kat bawah tu.
I think sama takut sikit nak tekan, but because PC pun was very near.
That's why macam mana dia nak makan banyak.
Dia tak ada on off ni, dia probe tu. Ada isu dengan probe.
There was, masa ni I was struggling lah because somehow dia tak, I don't know how to explain it. It was
Dia tak jalan. On dia only 8, off only 4. Macam tu tau.
it just didn't want. And then towards the end tu memang it didn't want to come to my probe, so macam kena
hilang. Somehow you're disconnected.
hello?
Dah, okay. Go on.
So memang a bit, even masa IA also the thing it didn't want to come. It has to be like somehow we have to like scoop it sikit baru dia datang.
Memanglah sebab rekod tak ada. Rekod minimum. Tiba tak PC kan?
Ni tak PC kan, alhamdulillah tak. But PC memang dekat lah kat situ. But I did masa IA because the PC was so near. In the end sama stop, I didn't dare because it was so near, and I asked Kak Ida to take over sebab dah macam nak dah tercapture, so I didn't want to proceed lah. Masa IA tu the PC was, the AC memang tak, I mean it wasn't deep enough for me. It was too.
Dr. Aziz, nak tanya, because this is last segment kan, then Dr. Aziz cakap the Feco power is not enough, right? So actually we can.
Bukan Feco power not enough. You have to differentiate between Feco power and duty cycle tau. Dia ada Feco power, dia ada Feco, tapi duty cycle dia tak jalan. Dia on 8, every millisecond 8, lepas tu dia off 4, macam tu tau.
So maknanya kita kena tekan more ke Dr. Aziz?
Yang ni obviously dia tak jalan sebab dia rosak. Sepatutnya wifi as you press, benda tu akan berubah ni, 8-4 ni. I thought I've shown you the graph earlier. Nak cari graph ni. Go on.
Because it was quite time ni sama buat jugalah, tapi takut.
It can be dangerous, you know.
Especially masa piece kecil-kecil ni, it was becoming more difficult to clear. Not so dekat kan my piece ni.
I thought I told staff to take it out. All this problematic.
We changed to IA time ni because because the lens pun tak nampak the dense that the thing would be better. Tapi masa IA ni pun I think tekan sampai ke bawah pun macam it did not, the vacuum was not tak jalan juga.
We look at other videos afterwards and tengok dia punya duty cycle tu jalan tak.
PC tu memang dekat.
Okay kan? We notice ada isu dengan FICO program kan? When you have this vacuum jalan, FICO ada, but duty cycle tak jalan, obviously you have problem with the FICO program. Or your cassette.
Masa ni sama tekan full, but then still tak things did not it wasn't coming lah.
Okay, proceed je sama. Okay, yang lain okay. We understand the issue.
Yeah. So subsequently masa IA tu, because the PC tu was too near, then I ask Kak Ida to take over lah. Yang tu video lain. So tu je lah Dr. Aziz. Mama Hani ada lagi satu kes.
Okay,
Tapi
before
saya
your... Mana dia?
Apa dia?
Ada ke
saya
case?
ni tak ada isu doktor. My case is a divide and conquer case. So
Oh, tak ada.
masa ni
Tadi-
tak belajar. Ada sekejap doktor.
Can I just before jalan, can I just share you one PowerPoint? Okay? I share sekejap. You all have to understand all these duty cycle.
Okay doktor.
Dengan ni, sekejap. I share mine sekejap. Share screen. Okay. Yang ni dah
Okay.
tunjuk dah misalnya ni. Nampak tak? Sekejap. Can you all see?
Yeah, can.
Can okay.
Okay.
Tengok ultrasound power modulation ni kan. So linear power. When people say linear power, people press. As you press down, kalau setting the FICO continue, dia akan naik, dia naik je. Linear power kan. When we fix that FICO burst, kan, this is FICO burst, dia punya duty cycle ni makin as you press down.
Tunjuk.
Hello, Mani, okay tak? Can you all see this?
Yeah.
Yes, doctor can see.
Okay. FICO burst kan, as you press down your foot pedal, duty cycle becomes more, meaning dia punya on off tu. You look at on off, on become more, as you press down, on become more, off become less. Kan? So dia jadi rapat kan. So FICO pulse, linear power as you press down, the power increases, but the duty cycle remains the same. White star is special. White star is that yang dalam teknologi dalam signature pro, as you press down, dua-dua naik. Linear power dia naik, power as you press down, the power increases, and also the duty cycle increases. So as you press down your foot pedal, the on off should change. Faham Salma Oh Salma, Mani semua faham
Faham Dr. Aziz?
Boleh faham Okay. This one you have to remember. You have to print this in your mind. The ultrasound power modulation. FICO burst, FICO pulse. Signature Pro has both. So as you press down, the power increases and the duty cycle also increases. Macam Centurion, dia tak ada ni. Dia tak ada, it doesn't work with this FICO burst or FICO pulse. It works with Ozil. So they don't feature this. They only fix their power. So power is fixed and then they use Ozil. Faham Okay. So dalam picture tu, dalam parameters tu, it should change. On off should change. Yang tadi fix. So something is wrong with the probe. Alright. Dah, stop share. Okay, Mani, go on. Ada. Who's next? Mani.
Okay. This case is 59 years old with known case of asthma and cataract of NS2 plus and PSCC, vision of 660. This case, I actually did divide and conquer technique. At this point, I haven't learned the FICO chop technique by Dr. Aziz. So I started with CCC. My CCC is slow. So I hope next time my CCC would be faster.
Slow but safe is okay, Mani. Kalau laju pun unsafe, no, there's no point kan.
Saya lajukan sikit lah kot. Because too slow. Then proceeded with the hydrodissection.
Saya ingat atas tu jadi besar sikit.
Dia betul-betul dekat ada border. Tapi it's not extended lah. That one.
We go direct to the issue lah, and the one that you have problem.
Actually tak ada isu sangat.
Boleh jadi this one you can do kan?
Yeah, this one actually saya buat divide and conquer Dr. Aziz. So masa ni tak belajar lagi chop. So next time I hope I will do chop more, I could chop more. Dia actually tak ada isu sangat lah Dr.
Okay je divide conquer kan, tak ada isu.
Yeah. The cataract pun not that dense. I think macam tak ada apa-apa sangat kot Dr. Aziz. Sebab yang ini je video yang save okay, because yang ada from the OT2 tu yang lain macam tak boleh save. I'm not sure why. So hopefully after this I can record more. The lens inserted at this point, in this case was tetanus. Cuma yang masa IA tu, the sub-incisional tu saya a bit struggle to catch. In the end, I just left small piece of it. So sorry. Then the lens insertion part.
Tak keluar parameters ni.
Yes, betul.
Tak keluar parameters kan?
Tak keluar parameter yang the Signature Pro on OT2 tu tak keluar parameter.
This is Signature Pro bukan.
This Signature Pro betul. Kalau Stellaris tu baru dia keluar.
We don't have overlay dia ada.
Yes, betul. So actually nothing to share about this. It's just about the divide and conquer technique that I'm actually last time used to it, but I plan to change to chop technique. I hope I can. So itulah.
Video. Jangan. Apa lagi? Tak present?
Tak ada siapa dah Doktor. So hari ni just 3 case je.
3 case ya? 8-19 dah. Baru ada masa lagi ni. Tak ada video lain. Mana? Sini tak prepare
No, Doctor, I didn't prepare for this session actually because I thought they were enough already.
Cuba kita cari yang tadi kan pasal apa dia, duty cycle tu kan. Can we just look at few videos Tengok ada tak memang jalan ke tak.
Dr. Aziz, can I ask a question?
Go ahead.
Should
Okay.
just now you mentioned about the duty cycle and the continuous and the burst mode and pulse mode. So my question is, if we were to do continuous, you encourage us to go in intermittently step 2 to 3 to encourage eating the segment during nucleus removal.
Sebab dia tak ada duty cycle. Dia tak ada duty cycle.
In pulse mode and burst mode, do we just, in a sense, we don't need to play step 2, step 3, we just press step 3 and then it will on and off on its own? Or do we still have to play?
You can, you don't understand, because as you press down, down the foot pedal, you have a linear changes. So you still have to play with the foot pedal. So White Star technology is very special because it's all linear. So it's very good for phaco chop surgeon because you have a full control over your duty cycle and power, because as you press, both goes linear. So it's a combination. You have to sit down and understand this concept. So most of other machines, and they have like all machines, they have, if we set phaco burst, it's only phaco burst as you press down, and if we set to phaco pulse, you will increase the power as we step down. Actually, we still have to play around with the foot pedal.
Okay, all right.
You shouldn't just press down and hope for the machine to change the duty cycle for you. It's all linear.
Okay, all right.
Kita check sekejap yang changes kan. Okay, sekejap. I check sekejap kan. Betul. When you change to White Star technology, it changes. Yeah, I show to you. Tadi continuous sama, betul lah. But we never change to variable White Star. Okay? I share one video. Since we don't have any other videos. How to share this? I share one video, right? Tadi 8 part kan? Because it's continuous. You put as continuous setting. Nampak tak ni? Can you all see?
Yeah, can, Doctor.
Can, Doctor.
Okay. I go direct to the setting. So yang ni continuous. Dia tak jalan sebab dia continuous. Dia tak nampak macam pedal kan? Foot pedal control kan? Okay. Ni continuous. When I change to variable White Star, variable White Star. Yang ni chopping kan? Chopping. Tadi tukar tak Salma? Setting left hand side ni.
Sorry Dr. Salma, dia dah pergi klinik Dr.
Okay. Tadi tukar tak tengok VFX ni continuous dia tak jalan. Tapi tadi tak perasan dia tukar ke White Star tau. Tengok dia tukar jadi 15/4. Dia, I'm not sure 15 on ke 24 off. Or the other way around. Something like that. Okay, dia tukar.
Nampak Dr. Aziz, nampak. Sorry, sama kena nak dilute ubat.
Nampak tak dia tukar? Dia tukar as you change. Yang ni, dia punya ceiling ni, dia fix at 15/24. 15 off, 24 on, or the other way around. But as you foot pedal tukar kan, dia tukar. It all depends on the setting that you have on foot pedal. Tadi nampak, tak nampak White Star 1 keluar tadi. Or because of your setting different. Because this one I set at medium hard soft ni, MHS. So kita tukar, we play around with the foot pedal, we play around with the on off.
Could it be that your setting has been tampered? Sebab macam semalam saya tak sedar dia orang tukar saya punya own setting. Then kata okay pula. Then dia kata oh ni Dr. Ida punya setting. Kata oh that means Dr. Aziz punya setting tu macam dah bertukar kot. Sebab last week kita guna
need to
Dr. Aziz
recheck.
setting.
Every time you start, you need to recheck your setting. You have to remember your setting. But this one is the polish or whatever refined setting that we have done to this machine. MHS. Takut benda ni pun tukar juga. Once in a while we ask Priyan to recheck. So ini fully controlled by foot pedal. As much, your movement of foot pedal determines your power. Dia makan banyak mana. Okay guys, yang tadi Faco burst, Faco pulse tu kan, you all have to read that lah. Okay, any other question? 85 dah. Anything else Sri?
Sorry Dr. Aziz, maknanya yang tadi tu, yang sama punya vacuum tak jalan is our setting lah
Setting is continuous. Continuous dari mula kan, sampai habis. You recheck.
Yes.
It's continuous. I don't use that setting anymore, sama, because we have different other setting. We have refined that setting to include the white star.
Okay.
You know, the VS ni. White star technology, something like that. Variable white star technology. So it should change as you press your foot pedal down. Yang tadi continuous all the way. Alright.
Thank you Dr. Aziz.
Ada lagi soalan? What else did we discuss yesterday, Sini? Sini, Sri.
Yesterday was mainly you asked about the last segment setting lah, like why when we change, what is the changes lah. Yeah.
And you all have to understand why we hydrate the wound. Remember?
Yes.
You cannot just follow whatever people told you to do, and turun-temurun from your senior to junior. You have to ask what's the reason behind it. And even the creation of wound, why you create a wound, how you create the wound, that you need to explain. And we create a main wound because we want to create a flap inside, kan?
Yes, Doctor.
It's not just for the sake of creating the wound and secretion of the flap, internal flap, so that you can close from inside.
Yeah, Doctor, but I still hydrate everything because I think now with my skill I still manipulate quite a lot at the wound side, like pressing and everything in and out. So I don't think my wound will sell still if I don't hydrate it.
And the other example is when we discuss why we have fiber inside, right?
And because during actually when I'm checking the wound also sometimes a bit too overzealous, I think.
We have been doing it repeatedly, repeatedly. You check, you press the wound using your cotton bud. After that, you form the AC and you inject AC, form the AC, then hold soma hydrate repeatedly without realizing you're actually forcing the fiber to go in.
Yeah, understand.
So you have to understand all this, whatever behind the steps, the explanation behind the steps.
Yeah.
Okay,
Doctor.
Soalan before we end. We also live stream on YouTube. You can look at it later as well. Okay, shall we end? Go to clinic. Okay. I'm okay.
Okay, thank you, Dr.
Thank you, Doctor. Thank you.
All right, bye.